the average age is 45.8, and the average age for the healthcare trust is 39. So even when you add your dependents, which would be your children and your spouses, you're still running higher. Let's go to the next page. So, this page is just really about, are claims coming from dependents or are they really just coming from employees? And when you look at the graph at the bottom of page 2, the blue, the darker blue is your current medical and prescription drugs paid by your employees. You can see it's slightly up this year over last year. Last year is the light blue, and then the benchmark or the typical Mako book of business, you can see your claims are up over that. You can see you virtually have no claims from, a little bit from spouse and none from dependents. So that's just kind of showing you that your claims aren't being driven by other people that are on your plan, but just really by your employees.
Okay.
The bottom of page 3, instead of going through those graphs, which are kind of weird looking, it says at the bottom of that, Muscle Shoals County has a current risk score of 1.22 and a prospective risk score of a 1.13. So we like risk scores to be at 1, right? If I'm you want like just a normal healthy person, their risk score should be at 1. Well, yours was 1.22 this year, and next year it looks like it's going to go down. That's probably because, let's say that somebody had a hip replacement. Well, if you had one this year, it's a one and done. You're probably not going to have a hip replacement next year unless you have to do the other side. But a lot of times those types of surgeries, we're not expecting that to continue long term.
Then we had one of those, and then we also had a tire blowout on a truck. And that was very expensive for that employee, because it ran off the road and bunged up his neck and everything. I mean, he's still not working full time.
Right, and that actually probably was covered under work comp.
You're right.
Was it?
It was.
Okay.
I would assume that the majority of his care was covered. I do know who you're talking about,
Yeah.
and we don't want to say names ever.
Well,
because-
and that's true. Well,
But yeah, I'm
It was Mike,
assuming.
wasn't it? No, I'm just kidding.
Yeah, you're right. It was Mike. What were we thinking? So
The tire blew on your
Everything
brand new
is
truck.
covered.
yes, right. So, on page 4.
But is that really what you're saying is,
that wreck did not.
It didn't
Did
show
not
up.
show
It
up
doesn't
in
show
this?
up in any of this.
Okay.
it's covered under a different insurance pool.
Exactly. You're probably covered by the state fund for that,
Yeah.
aren't you, right now?
Yeah, workers' comp.
Yeah.
But is this what you're saying with this, like this gets my attention, 1.22, that we're, as far as premiums received versus what's spent, is it kind of like your experience modifier for like you've heard of like a safety experience?
I'll go into that in a few
Okay,
minutes.
all right, I'll
It's a
let you keep
little
going.
bit different. We do have, typically a mod factor is really a P&C term or a work comp term, not necessarily a health term, but we do use that term in ours, and
Okay.
I'll review that a little bit further down the conversation.
Okay, very good.
But just, it's an indicator that the Allegiance system uses to indicate the overall health of your group right now and what they think is gonna happen in the next year. So they think your group is gonna get a little healthier, this year or this coming year compared to this year.
Okay.
So the top plan by service, which is the top of page 4, you can see the dark blue line is your reporting. You can just see that you have a lot more services that were considered outpatient than last year and also than a typical book of business of a county your size. And so outpatient could be an outpatient surgery, like if I have knee surgery, that's gonna be outpatient. It also could be an infusion if somebody has cancer. They're gonna go to an infusion center. They're usually not hospitalized to receive something like chemo. So you can see that, that's really what led your claims by category was outpatient. You had some inpatient that was above last year and above the book of business, and then pharmacy was up as well. down below the largest dollar increase from last year to this year, it says AFib, or, which is the very first one. Well, it was such a small dollar amount last year, you probably didn't have anybody that was really seeking much for treatment last year compared to this year, and that's just why, you know, same thing, cancer therapy, you had no dollars last year, this year you had some. So just know that, a lot of times, these numbers look a little weird because if you didn't have any, it looks like it's been a huge increase. But it's just because we didn't have those, health conditions last year. So when you flip over to the top of page 5, durable medical equipment, the thing that I don't like about this graph right here, it looks like durable medical equipment, like you've had a huge increase in that, right? Well, when I think of durable medical equipment, I think of things like walkers, wheelchairs, crutches. But in the Allegiance system, it classifies something from the durable medical equipment really as if I had a hip replacement and they put a titanium ball in my hip joint, that would show as durable medical equipment, even though the typical American, when we think of DME, we're thinking about a walker and a wheelchair, things like that. So you can just see your top procedure groups, the increases, you know, you had no oncology last year. This year you had oncology, you can see surgery is up, operating room is up, imaging and radiology.
Well, you know, looking at this, it's like these were up a lot.
But remember, like oncology, if you had none last year and then you have some this year, it's gonna make it
Well,
look
I,
like.
I think, yeah, the zeros, okay.
Yeah, and then same thing, like durable medical equipment, you know, you didn't have anybody that got maybe a hip or something like, some kind of a joint that's been implanted in their body or some other, you know, it could have been a heart, something put in somebody's heart. If you had none last year and then you have one this year, it's gonna look like such a massive increase, partially because you're a smaller group, so one thing, you know, one event can really skew your numbers.
Right, I mean, well, I mean, I'm just guessing, and I would presume that's kind of the same thing when you're looking at, like, surgery, right? Well, 32,000 might have been, last year we might have needed 1, this year it was 2 instead of 1.
Exactly,
Right.
right,
Mhm.
so,
With 50, it doesn't take much to make this just go like that.
Yeah,
absolutely, right. So,
okay.
one thing that's maybe a little bit different on the bottom of page 5, here, you guys are part of the health district, right?
Right.
Well, if the people from the health district ever came to you and said, hey, what should we work on in terms of trying to make county employees more healthy? Well, these are your chronic conditions that, you know, some work could be done. So the first one is diabetes. A typical county your size, the typical book of business is gonna have 4 diabetics. You guys actually have 11. So you have way more people that are diabetic than normal.
This
In
is,
terms-
this is per our population in the county,
This is your prep, yep,
so it's
your
11 or 11%
11
11 out of
individuals.
55 roughly.
Yep.
of our members?
Yeah, 11 of our members out of our 55, when they're saying you really should have about 4.
We hire
And
Really, they actually have the diabetes or they're
Buying them
diabetes?
donuts every day.
They have,
Well, there's some
they
in
have a
there.
diagnosis of diabetes,
It's
Really?
an epidemic
I'll
in
be
the country.
darned.
It
It's
is.
a countrywide
Oh, yeah.
epidemic.
right,
it.
It's
But-
processed food.
right, but when I look at the next numbers, hypertension is typically the highest, it's usually number 1 on almost every county. It's usually hypertension, hyperlipidemia, diabetes, depression, and lower back pain. So you can see your hypertension, high blood pressure, you're right in par. Hyperlipidemia, which is high cholesterol, you're slightly under. Lower back pain, you have more people with lower back pain. Osteoarthritis, you're double what they think that's a group your size. Depression, the good thing you're under. Like I was in, I think Hill County, that's their number 1. It used to be their number 1.
Really.
Yeah, so it's just varies, but you can see where a normal book of business, these are the numbers we would expect, and these are the actual numbers of your employees that have those diagnoses. So you can see blood disorders, you're down, you know, less than what the book of business, but AFib, you're up over what,
Well, if you tell us which employees they are, we'll fire them.
Of course you will. Yes, right.
That's, you're thinking out of the box.
Brain.
Yeah,
You're being recorded.
thank you. So,
It could be us, Rob.
I disagree with the elected officials.
only people that are on the plan, let's keep that in mind.
Okay.
The care alert score, we actually like those numbers to be higher. And also, what I mean by that is these are people that we know that are properly taking care of themselves. So, for example, if I'm a diabetic, I probably need to have 1 or 2 retinal eye exams a year. I probably need to have 4 hemoglobin A1Cs because they want to know what's happening to my blood sugar. I probably need to have 1 or 2 foot exams every year. Well, so the higher these numbers usually indicates that people are taking care of themselves better than, you know, like for example, your chronic disease, it came down. Last year it was 37, this year it's 32. So some of your people are not taking care of themselves as well this year as they were last year. And when you get to the bottom, like the reporting period and the comparison period, and you see numbers like 65 and 55, and maybe you only have 50 on the plan or 55 on the plan, just know that some of those people have more than one health condition.
Oh, okay.
So kind of keep that in mind. The good news is though, over on page 7, this is one of the #1 things we look for. You have no frequent flyers, people that are abusing the emergency room. Also, we see people, we don't see anybody that isn't going to the emergency room unless it's for a high severity or a life-threatening condition. So the people who did go to the emergency room, they went for the proper reason. You know, I was in a county that they had 4 people that went to the emergency room 6 times or more. If we have people that are in those situations, that tells us one of 2 things. They probably either don't have a primary care physician, and so they're using the emergency room as their doctor, or they don't know how to manage their health condition. And then we have people at Allegiance reach out to those people to make sure that they're getting the care they need, or if you know, they don't know how to manage it, that they'll help get them the services and get them so they're trained. But there's no abuse in emergency room. So interestingly enough, it looks like you did maybe have a couple people that went to the emergency room that maybe wasn't necessarily like lower back pain. Let's use that as an example. I might go, but it might be because I fell and I don't know if I broke my back. A urinary tract infection, people will go because sometimes the symptoms for them that will feel like a different health condition. But just know, like, if we saw a lot of those types of visits, you know, Allegiance would reach out and be like, hey, did you know that you can call the toll-free number on the back of your ID card and use telehealth for a urinary tract infection? And it costs $40, and instead of going to the emergency room, which a lot of times going to the emergency room is your only option unless you know you have telemedicine, or, you know, when we live in rural areas, if it's on a weekend, you have to go because there's nowhere else to go, or you're gonna drive your 40 miles too. So over on page 9, I'm not gonna spend really much time on your top 20 drugs because I could just look at them and tell that probably all of them are for diabetes except for one of them is like a blood clot or cardiac condition. Brio is actually for asthma, but it just looks like those numbers have changed. And there's a different section we're going to talk about pharmacy a few pages down, so I don't want to spend a lot of time here. And you can see, like, at the bottom of page 2, you know, your big numbers are coming from diabetic and then miscellaneous, and I don't really know. Sometimes Allegiance will just categorize things in miscellaneous, and so that's hard for us to interpret. On page 10, this is talking about pharmacy usage.
Actually, can we go back to like the
Yes, of course.
So you're showing that, you know, we basically got some more people on certain drugs that weren't on them last year, or, but there's not, when it comes to something like that, maybe I'm going way too far, but is there any way to change that, other than,
Well, first of all, that's a really good question. And I don't want to read into it too much this year because, for example, let's just talk about Monjaro. It's the first drug right there, right? Well, when we switched pharmacy benefit management companies, I'm sure you remember this,
Yeah.
in July. Well, it was previously, Ozempic was a preferred medication with our previous carrier until the manufacturer, because of the shortages and the abuse of that drug, they pulled it off of the PAP, or the patient assurance program.
okay,
Well, when that happened, everybody that was really a diabetic and needed a medication like that, they shifted to Monjaro. And it was because of us switching pharmacy benefit management companies, so it skews that. So don't read too much into
Okay,
that this
okay.
year, but next year we'll wanna look at that and
but if you don't have any more people than you have this year, next year, it's not gonna show up. This is really compared to last year, right?
Yes, that's what that reporting period. At the front of this booklet, on the very front, it said this is the reporting period. So when I say this year compared to last year, I'm
Yeah.
going February of '24 to January of '25 compared to February of '23 to January of '24 of the previous year.
I am with you, but it could very well be that a lot of this is because, just like you said, you switched your,
Absolutely, and you're gonna see some of that on the next page. The one thing that is a little alarming is on page 10, and there's nothing, I say it's alarming, there's nothing we can do about it. So single source drugs. What that is it's a drug that you can only get that drug from one manufacturer in the United States. Well, what happens if you can buy drugs from lots of different manufacturers, it forces the price down, right? But this, my guess, would be something like a cancer drug. It's something that is a specialty med that they're not going down to the pharmacy and picking up. It could be being sent to an infusion center, could be sent to their doctor or their home, but it's probably some type of an injectable, and there's only one place in the United States to buy it, and so your usage of single source brand drugs is at 90%. The typical Mako County is at 75%. But honestly, if that's the drug they need, there's really probably nothing that we can do about it, because there's nowhere else to buy it.
Right.
So, and back to, let's pick on Mike. The good news is when you see, Mike and Mike, when you see these numbers at the bottom of page 10, you can see where, you know, typically people that have drug expenses that are significant, a lot of times, the more you age, the higher those numbers are gonna be. But you can see, you know, between 60 and 64 are your highest age groups, and the next age group actually falls down. And if you look at it, your group from people that are 35 to 39 is really, you know, about the same as people that are age 50 to 54. So something tells me that you
The
have
star
somebody.
doesn't go high enough.
You're right, it doesn't, of course it goes high enough, come on.
There's a pilot that already died.
So,
You know, what I'm seeing here though is, there are some, well, I should let you finish, but
that's okay.
I'm seeing some where, you know, you have someone who has diabetes, where he's also going to have a heart condition too. They're all related.
Absolutely.
All of these little things are related. So we probably should look at making certain that they're a little more healthy. I mean, a little more active. That would take care of a lot of that. Especially like the, you know, diabetes. That's half of diabetes comes from someone who does not take care of their health. Being overweight, not getting exercise. Next thing
not
you
eating
know, you
properly.
turn diabetic. And drinking too. That doesn't help a damn bit.
Right.
Yeah, but I'm trying to quit.
Well, so am I. But
I'm eating or drinking.
Right. So on page 11,
Okay.
this here shows that the gross costs from, this is only about pharmacy. Okay, so only about pharmacy. Your gross costs for your plan, the people in your plan, it went up to about 10%. So the gross cost was 140. The plan costs, our portion that we pay went up as well. But interestingly enough, if you look at the next one, when we shifted pharmacy benefit management companies, your patient share went down slightly. It says it went down, 28%. So the good news, even though we switched to NACO, the National Association of Counties, we moved to their pharmacy plan because we knew it should save us about $3 million this year, which we only have about 6 or 7 months of that in here.
Okay.
But to me, that's an indicator of why your patient share went down. But the good news is when we shifted from that company, we didn't just shift the change to your employees and made them pay more. It's that we negotiated a better discount that saved money overall for your members. So, your planned cost per member per month on average is $166. And when you go down into the patient intensity, kind of right under there, it looks like you have, some patients that take specialty drugs. See how it says 43% or more are taking 5 or more medications? Don't freak out about that. Because that sounds like a lot, right? 43% of your people. But this is why I'm not alarmed about it this year. Because let's say that I took a certain brand of a thyroid drug up until the time we switched to the new company, and they made me switch to the preferred brand. That's going to show as 2 prescriptions. So I think next year when we look at the numbers, they're going to make a little more sense. But right now, those people, a lot of those people are showing that they had 2 different drugs when really it was just the same drug. But because we switched pharmacy benefit management companies, they've also had to switch to a different brand of that drug. And that could be what's skewing that. And so that the next box, I'm sorry, this print is so tiny. You can see where, diabetics, the percentage of change from the prior year was up, opioid was down, mental health was up, circulatory was up, asthma COPD was down. And right under there where it says patient movement, leavers and new patients, all of those people that left, 18 of them, it's probably because we told them, hey, your medication isn't preferred on our new company. And so then they've had to move to a new drug. So I would say at least new patients or new prescriptions, that 49, probably at least 18 of them, or because somebody had to switch because we changed pharmacy benefit management companies. So these reports aren't great this year because we only have, a half a year and it's just not maybe lining up. The top therapy groups, kind of at the bottom in the middle of that page, you can see diabetes currently is 59,000. Last year it was about 48, so that's up. Your anti-inflammatory is down though slightly, so those 2 kind of switch places. So this next page, if for whatever reason there's somebody that's sitting here that feels like you can look at this and know exactly who these claims came from, if you don't feel comfortable having these reports in your county, because we don't want this to be a HIPAA violation. We don't want somebody to look at this and be like, I know exactly who that came from.
Right.
And so I've actually had a couple counties that the commissioners gave these reports back to me because they're like, everybody in the county is gonna know who this claim came from, and we don't want that to happen. So just if you feel that way, just know that I'm happy to take these reports back. But you can see you had 5 of your people, so about 10%, that had claims that were what we would consider a large claim. A claim, anything that was over 50,000. And remember, that's our pooling point, and I'll go into that a little more. So you can see that, 5 people, we had over 300,000 just from those 5 people. So when you look at, just even take into consideration, guys are probably paying us $50,000 or $60,000 a month for your claims. From those 5 people, we had to use half of the year's premium just to pay those. Doesn't count anybody else that didn't have a so that's really where pooling comes in and helps you. The remainder of this report is just about the wellness screening, the blood draw that we came and do for free for your members. You can see that you only had 16 of your employees participate. The average age of the people that came was 54. And as you flip over to the next page, you had 37% participation rate. So you have a third out of about your 50 eligible. We only had 15 that came, 12 were males, 8 were females. I never pay a lot of attention to the blood pressure down below because if I'm going in for a blood draw, that means somebody's coming at me with a needle and I'm gonna have high blood pressure. But when you look over on the next page, you're out of range, both for your males and your females. Those are high percentages because green means good on these circled graphs. Green means good. Of your males, what is that, about 57% of them came to them. Their hemoglobin A1C, which is your average blood sugar over the last 3 months, was out of range. And almost half, 43% of your females, they were out of range. Down below your lipid panel, you're seeing where people with cholesterol issues, out of range. The good news is, you probably had one female with the thyroid condition that maybe she wasn't aware of. But almost everything there on the next page looks really pretty normal. What's shocking is your vitamin D levels, which is over on the last page of those graphs, they look really pretty good. And of all the males that had PSA tests, they were all in the normal range. The one thing that I do look for on the last page of this report is the third paragraph down. So you had what, 15 people that showed up? Within usually about 48 hours after the blood screen, after they've processed the drug, the blood, the medical director from Rocky Mountain reached out to one of your employees and said, hey, you have a serious health condition. You probably need to go to your doctor right away because you need to either do something to improve these levels or you have a serious condition that you need to have addressed. So we're really trying to find health conditions early because early detection and early intervention is really what saves money. I went through that kind of fast, but I think it gives you a good idea of, what's driving your claims. And so if we want to go back to the agenda and the letter, the renewal letter. Does anybody have questions so far? Or should I keep?
No, this is, it's a lot of information, but I think it's quite telling.
Okay. So the healthcare trust, and maybe I should have, feel free to chime in at any point.
Yeah.
We kind of had a tough year this year. More than half the counties had loss ratios of over 100%. And so really what that means is for every dollar we took in, we didn't pay out, or we paid out more than that to pay for their claims, right? And so what that means is the healthcare trust, we need about 10% to operate. A typical insurance company is going to need about 20% to operate. But when we don't collect necessarily enough from counties, that's when we start having to make adjustments. So ultimately, the healthcare trust, when the people like Ross, when they set the rates, they finalized the overall rate increase at a 9.8%.